Thank you, Sean. Good evening, everyone, and thank you for joining us today for this webinar on gender-specific care after solid organ transplantation. My name is Valentina Ricci, and I will be moderating this webinar together with Umberto Cillo, whom I'm pleased to introduce. Umberto Cillo is Professor of General Surgery and Chief of the Hepatobiliary and Liver Transplantation Unit at the University of Padova in Italy, where he's also responsible for the pediatric liver transplantation program. He's the author of more than 350 peer-reviewed publications, 28 book chapters, and 5 books. His work focuses on transplant oncology, transplant allocation, immunosuppression, and oncologic hepatobiliary surgery. He served as president of the Italian Society of Organ Transplantation from 2017 to 2019, and has been an ESOT counselor since 2017. Last but not least, he is the co-chair of the ESOT Congress, which will take place in Milan from August 29th to September 1st of this year. Umberto.
Thanks a lot, Valentina, for this nice introduction. Now is my turn to interact and to present you. Everybody knows you, basically. All the people by ESOT knows you very well. Valentina Ricci is Senior Education Manager at ESOT, is really core of ESOT team. She obtained a PhD in philosophy at the University of Padova and at the University of California, Irvine actually. She had been working at the University of California for a long time, actually until 2018, and then she came back to Italy. Now she is absolutely deeply involved and responsible for the whole educational portfolio of ESOT, and so is a massive work she's doing in ESOT so far. And if I can add, she's now launching, she has been launching the Diversity and Inclusion Initiative, and she's responsible for this development in these days in ESOT. As you know, this is a very important initiative of ESOT, and we really care about it. So thank you, Valentina, for being with us. I'm particularly happy to chair this webinar, and I want to thank for the invitation Anna Forsberg and Christine Falk, which are the creator of the concept, the idea of this format. I want to just explain to all of you that are not aware of it, that these webinars are a number of webinars that are going to precede the ESOT Milan Congress that will be held in August 29th to September 2021. And this is a very original way to approach the ESOT Congress. What we took the advantage about the pandemic, crisis, the COVID-19 crisis. Everybody's more used to virtual connection and teleconferences. So our idea was to hugely enlarge the possibility to expose and to go in deep to topics that would have been not able to be included in a 4-day Congress program. So the ESOT Milan 2021 will be a large conference that is starting in spring, going through summer and ending September 1, and probably also having some post hoc, in a way, activities. So this webinar is one of the key webinars. I'm very happy to be here because it's included in what we call the value-based care domain. The Congress will be divided in 6 major domains. One of these is going to be value-based care. So it's a different way to approach the clinical transplantation, because we are a little bit sick and tired to look at transplantation only according to safety, efficacy, Kaplan-Meier survivals, graft and patient survival. We are now approaching in these years a new, more holistic way to look to what we do and to give value to what we do, more holistic in the sense that we are looking to the human being much more than only to the patient. And the webinar we are presenting today, which is the gender-specific care post-transplantation, is exactly, and as exemplification, is a paradigm of this idea. Because when you talk about gender differences, you not only are able to approach the issue from the point of view of the biology and the clinical and the science that is behind biology, but you're also looking to and psychological and social approaches. Again, looking at the person much more than at the patient, looking at the human being in a more comprehensive way, much more than in the past. And the gender-specific medicine is something that is going in this direction very particularly, and we are very interested into that. I just one more minute before presenting the outstanding parterre that is going to present and speak today. I will see them in a minute, but I just want to launch a little bit more the idea that ISO Congress in Milan will be an in-present conference. Of course, we are going to have an hybrid solution in the sense that all those that will be not able to be there, to be in Milan in person for any reason, will anyway be able to see the content of the program. But our intention is to have an absolutely in-person usual conference. And what we are seeing around, as far as, for example, Italy is concerned, is that there is a very advanced vaccination plan. The safety of the situation is improving, and we foreseen that within August we are going to have a very open kind of society, much more than it has been done. It has been seen in the last month. So please consider immediately from now to be in presence in Milan, much more than connecting. Let me stop here and give it back to Valentina to introduce the speakers.
Thank you, Umberto. And before I introduce the first speaker, just quickly, I would like to mention that, as you actually refer to, this webinar is also organized in the context of the Diversity and Inclusion Initiative. And specifically, it is aimed at pursuing one of the key goals that we have, namely to be more inclusive when it comes to research. And we are really glad to be organizing this webinar along with Women in Transplantation. Next, I would like to encourage everyone to complete our survey on equality, diversity, and inclusion. The goal here is to really hear from the community and to build the roadmap together towards greater equality, diversity, and inclusion indeed. You can find more information on our website, and you can complete the survey until June 6th. Now, to the program of the webinar. As we already mentioned, we have an amazing lineup. Anna Cristina Breithaupt from Brazil, Anna Forsberg from Sweden, and Fernanda Ortiz from Finland, and you'll hear more in a minute about them. In the meantime, I encourage you all to submit your questions in the Q&A box in your Zoom interface at any moment during the presentations. We will then address them all together at the end during the Q&A session. Now, I'm really delighted to introduce our first speaker, Anna Breithaupt. She is a scientist and the coordinator of the research activities of the Cardiovascular Surgery and Circulation Pathophysiology Laboratory at the University of Sao Paulo Medical School. Her current research interests include studying the repercussions of brain death on solid organs and sex dimorphism, focusing on mechanisms of estradiol influence on immune responses and vascular activation. She's additionally involved in research on ischemia and reperfusion consequences and remote injury. Anna, thank you for being here.
Thank you, Valentina, for the kind introduction. I'm starting sharing my screen now. I would like to start thanking ISOT by the opportunity to be here, showing some of our results on sex differences in brain death donors. We will then start. I have no conflicts to declare. So when we think about sex differences, it's immediate for everyone to think about men and women and the basic differences we all know. But it's important to have in mind that all we have, not all, but the main content that we have of knowledge regarding treatment, diagnosis, prevention of diseases are all information gained with research and clinical evidence on male animals and men patients. The main content of our knowledge today has started and is focused more in results gained in the male sex. So today I would like to enlarge a little bit that and to focus more on understanding what sex introduces as a difference. When we think in sex differences, we have to consider that they can come from genes and from sex hormonal influence. When we think about genes, we have to remember that normally when we think about sex influence, we think always on the sexual chromosomes, and we have differences starting from there. We have in female individuals double X's that are randomically inactivated, and these inactivations allows for the female counterparts to have more variety in their cells. So we have one randomically inactivation occurring in each cell, and not always the same X chromosome is inactivated. So despite the fact that male counterparts has X's also, they will have only the same X in all the cells. And the Y chromosome is giving other characteristics. So we have to consider that these differences start there. And we have these differences for the whole life. It's not going to be, they are not going to be altered by the hormonal milieu. So after the puberty, you start having the influences of sex hormones. And these hormones are going to influence these cells, or the whole bunch of cells that we have in our organisms, through receptors, specific receptors, and doing things that can improve and enlarge these differences. So we have to consider that what we know for now is that these sex differences could influence the life expectancy, the metabolism, the behavior, all the diseases, including the results of these diseases in prevalence, and also in the way these diseases appears in each individual. So it's important to consider this as a large topic of discussion. And with time, it's getting more and more important to consider the influence of sex in all of these aspects. So here we are focused in transplantation. So what is the sex influence in transplantation? Normally, when we try to search a little bit about it in the literature, normally we find a lot of articles focusing on sex matching between donor and recipient. It's a good thing, it's a bad thing. It's good to have a matching. For example, the donor is a male, the recipient should be male. Or it's not a problem to have a female organ to a recipient that is male. This discussion goes on, and we have a lot of literature on that. Some of the articles already pointing some key things showing, for example, like this, when we see that for the heart transplantation, maybe the female heart does not reach good results in male. The results are poorer. So for example, the prognostic of the transplant is not so good if you have a heart from a female going to a male recipient. We have the same situation for other organs, but there is no consensus. We do not know if this influence is important or not. In my opinion, it is important, but when we think about organ donation, we have lack of organs. We have very full queues of patients waiting for organs, and we do not have enough organs for them. So thinking about matching is complicated. You have to match any other aspects, and sex should not be the first or something that should be considered at first. So I believe that the study of sex influence should give us more information if we focus on organ quality and donor management. Maybe we should focus, does sex influence on the organ quality? Should we change the donor management regarding the sex of the donor? These are more important questions, in my opinion, because we have to consider that there is sex dimorphism in organ size, in organ characteristics, that we should know. Some of them we already know. For example, normally a heart from a female donor is smaller than a heart from a male donor, normally. We have, for example, sex hormones affecting the physiological process. Now we know a lot about the influence of the sex hormones in the cardiovascular systems, immunological responses. So it's important to consider the sex difference in this physiological process in the donors. And another thing that's also important is to see which kind of donor do we have. We have a living donor, we have a brain dead donor, we have a DCD donor. Maybe the influence of sex is different if we consider a living donor, a brain dead donor, or a DCD donor. So a lot of study is necessary to understand completely these aspects. In our lab, we are more focused on brain dead donors. We use experimental models trying to understand the effects, the consequences of brain death in the donor, in the organs. So we use a classical brain death experimental model based on the sudden inflation of a balloon catheter inside the intracranial space. We use normally rats, and these rats are maintained for 6 hours. During these 6 hours, we accompanied the pressure and the cardiovascular system. And after 6 hours, we retrieve the organs and analyze the results. So only to show you, we normally, when we do the inflation of the balloon catheter inside the intracranial space, we observed a sudden increase in the mean arterial pressure. We have a peak, and then we have some period of hypotensive. We do not manipulate that with drugs. We live like this, and then the normalization of the pressure. Here we have some results from the first study that we carried out, comparing female and male animals, and we see that the model does not induce differences in pressure. So the model works the same for male and female. Then I would like to show you some results. The first thing that we observed in analyzing the sex influence was that female animals present after brain death an acute reduction of female sex hormones. We observed after 6 hours that the levels of estradiol and progesterone are very low. And that effect is different when we consider, for example, our overectomized element. Because when we have the overectomy, these animals take at least 7 days to have the reduction of the hormonal levels. And brain death is able to do that in a few hours. We believe that we have the cut of the axis to hypothalamus, hypophysis, and the gonadal aspects. So we are not producing the hormones anymore. So based on that, we continue the study analyzing the organs, specifically kidney, liver, intestine, lung, and heart. By observing these organs, we could see that we found a higher inflammatory condition in the intestine, in the lungs, and in the heart from female animals. We found an increased number of leukocytes and edema in these 3 solid organs. By histology analysis, we could not find important difference in the kidney and in the liver. So we focused more in the lungs. The results from the lungs showed that we have increased number of leukocytes and also increased microvascular permeability. We observed also edema in the female lungs in comparison to male animals. All these animals were submitted to the same model and maintained it for 6 hours. This inflammatory response made us question if normally when we think about inflammation, we have to focus on the microcirculation. In the microcirculatory bed, we observe the inflammation occurring, the cells extravasating and going to the interstitium through this venule. So we studied in our lab the condition of the microcirculation. And by doing that, we observed that female animals, they preserve the perfusion of the microcirculation when male do not. They have a reduction, a significant reduction of perfusion in the microcirculatory bed. Here we did these experiments in the mesenteric microcirculatory vessels by intravital microscopy, and normally a normal animal presents like 70%, 80% of perfused vessels when we analyze the perfusion. And when we start brain dead, 30 minutes after the starting of the induction by the inflation of the balloon, we already observed the reduction of perfusion in male. And that did not happen in female animals. So in order to understand that phenomenon, we tried to focus more on the tonus control. And by doing that, we tried to evaluate one of the molecules that is influenced by estradiol, that is enos, the enzyme that releases in the vessels the nitric oxide. By doing that, we observed that female animals, they preserve the expression of enos in the vessel area in comparison to male that loses it. They have a reduction on the expression of the enzyme, and also the control of the tonus based on the nuclein-1. We have that preserved in females and lost in males. Maybe the control of vessels are prejudiced by brain death in males. In order to enlarge this comprehension and based in what we saw in the intravital microscopy, normally when we see these vessels that I showed before, we see like a huge line of red cells stopping there. And maybe we can see some dots that seems to be thrombi. And in order to understand if not only the tonus control was involved, but also the platelets and the formation of thrombi, the coagulation process between males and females, we analyzed that by intravital microscopy by targeting with antibodies the platelets. And here in these two videos, we can see the situation in brain dead males with the formation of thrombi inside the vessels. And here in a female, we see the flow maintained. The same situation as we saw before, but now with the staining of platelets. So we observed that for female, the flow was maintained. In order to see if the platelet aggregation was really involved, we removed platelets from the animals, and we saw that the counts of platelets was reduced in male, and the aggregation was inversed. Normally, female animals aggregate more. Female platelets in vitro aggregate more. And when we have brain dead female, we will observe the opposite. They change, and we do not have this aggregation. And in order to see if the coagulation process was in line with these results, we did the thrombelastometry with blood of these animals. And when we analyzed that, the clot formation time for females were a lot higher. So we did not have the formation of the clot normal when we have brain death in female animals. And when we see the firmness of this clot, there is lower firmness when we see the female animals too. And we see it a longer time. This clot firmness is not reached, so it stays low a long time. So with these results, I did not brought everything we have. I tried to focus on the more important results. So I made here a summary in order to review what I told you. We have more inflammation. The inflammatory infiltration is higher in female. We have more edema in female organs. The microvascular perfusion is reduced in male when it's preserved in female. We have reduction of platelet aggregation in female animals when we have the higher aggregation in male. And the clot formation is also altered by brain death in female. When we see the male, the clot formation is normal. Then I would like to end my talk. Here we only have to do a brainstorming. Maybe these things that we observe could give some insight to further studies to see if we should not manage differently female brain dead donors and male brain dead donors. What we think now, it's time to think differently and maybe treat differently in order to improve organ quality. Thank you, everybody. This is what I wanted to share with you.
Thanks a lot, Anna. Fantastic overview on the biology of donation. It's absolutely new to me. And just 1 sec in order to break the ice, and we are going to wait for the question from the audience clearly. I remind everybody, do make your question in the question and answer section anytime, and we are going to present to the speakers. But the idea is that you are absolutely opening a Pandora box, because when you say that there are clearly genetic differences, metabolic differences, hormone dependent differences, epigenetic, I would say, differences as well, this is going to clearly create 2 different populations, male and female, according to gender. And this is something that is scaring in a way, because it's disrupting the way we usually look at transplantation as a whole, you know. And this is the first issue. And the second one is that, absolutely in line with what you were saying, do you think that we have enough evidences in order to treat differently our donors, for example, with anti-inflammatory substances in female and more anticoagulants in male, till now, or we still need to wait for further evidences?
I would think that the studies in the clinical field should start based on that, to see if we see the same situation in patients. Do we see coagulation alterations in the male donors? We should consider that, start thinking about that, start studying that in order to do the changes if they are necessary and to improve the quality of organs. We have a huge lack of them. If we can contribute by analyzing these aspects, it would be very, very good.
Thanks a lot, Anna. We are going to have time to discuss a little bit more. We are already short in time, so it's a pleasure to me introduce Anna Forsberg from Sweden. Probably everybody knows Anna. She is one of the ISOT counselor. And Anna is a professor and a nurse, and her research interests have been including health science, nursing, intensive care, organ donation, organ transplantation, really a huge amount of topics touched in her career. And her research focuses in particular on organ donation and transplantation. But I would say more importantly, on the issue of person-centered care, which is something that we need to talk today, and we care particularly. And with particular reference to high-tech environments like the peri-anesthesia, nursing, pre-hospital emergency care, intensive care, and transplantation. So a huge amount of interactions that are absolutely in line with what we are talking today. Anna will present to us gender-specific symptoms of distress. So probably look into the psychosocial point of view in this particular topic. Anna, please.
Thank you for a very nice introduction, and it's a pleasure to be part of this webinar. I have nothing to declare, and you are welcome to share the details of this presentation. The rationale behind my presentation is to start our discussion and our awareness of gender innovations. And what is gendered innovations? It's processes that integrate sex and gender analysis into all phases of basic and applied research, and it's a way to assure excellence and quality in outcomes. It also adds value to research because it helps us to ensure excellence and enhancing sustainability. And it also adds value to society because it makes our research more responsive to social needs and to understand the difficulties of being a human being, in this case, being an organ transplant recipient. And as Umberto mentioned, it's also a necessary foundation for person-centered care, because we are moving very strongly towards the perspective of the patient with of the person with an organ, and instead of an organ in the patient. Why should we focus on gendered innovations? Well, 30 years of research have revealed that sex and gender biases is socially harmful. And there are differences between needs and behaviors and attitudes of women compared to men, and we need to address these differences. And it also has consequences. For example, in medicine, if you're not recognizing osteoporosis also as a male disease, it delays diagnosis and treatment in men. And it's also crucially important to identify gender bias and understand how it operates both in science, but also in technology when we develop different devices, for example, to relieve symptom distress or suffering. Probably you are all aware of this, that there is different definitions between sex and gender. Sex refers to biological qualities, as Anna was mentioning, while gender is more a socio-cultural process. And it also involves cultural and social attitudes. I will show you some examples from our research, and we started actually to focus on sex differences in symptom distress after transplantation already 10 years ago. It was a sample comprising 185 organ recipients. The majority were male, and it covered different organ recipients having different organs. And what we could see was a clear sex difference in symptom distress. Women reported more sleep problems, joint pain, edema. They were more nauseous and dizziness and had dizziness compared to the male organ recipients. But also they were more sad, and they reported less libido, and they were also bothered by their physical appearance more than the male recipients. So it was a physical aspect, and there was also a more psychosocial aspect. And then we have also focused on sex differences systematically in our large project covering self-management after thoracic transplantation. And we can see consistently that women report significantly higher levels of general fatigue than men. And also one of the key concerns is that chronic pain is much more common among the female recipients. They report significantly worse pain intensity than men. They also report more affective and sensory burden from the pain than the male recipients. And overall, they report significantly higher pain intensity. And this is, of course, a concern, and I will discuss it in a minute. And again, the female recipients were slightly more embarrassed by their looks and also felt nauseous, while the male recipients reported more problems with increased appetite. But here the sex differences were quite small, and that's also an important result, that sometimes there are no differences due to sex, and we need to treat the symptom distress in a similar way afterwards. If we look at the lung recipients, there is also the same familiar pattern, that it's very common with chronic pain. Also in this group, the women report higher pain intensity and much worse sensory and affective burden. And they had a higher odds of experiencing pain when adjusted for psychological general well-being. So there is a link between, there seems to be a link between psychological general well-being and pain. And if you have good psychological well-being, the lower the odds of experiencing pain. And if that is due to the fact that if you have a good coping strategy or a good mental health, that you cope with the pain problems better, we don't know. We need to study that further. But there is a specific link between psychological well-being and the pain problems. We know after lung transplantation that it's very common with fatigue, and we could see among the lung recipients that the female recipients suffered more of mental fatigue than the male recipients. Female lung recipients also report worse joint and muscle pain. Specifically, again, the sleep problems is obvious. Also, female lung recipients report more worse headache, while male lung recipients report more problems with tremor or trembling hands. So, what shall we do with this information? Well, the male body has long been taken as a norm, and female bodies have often been studied, as Anna mentioned, as they deviate from that norm. And rarely does an observed difference between men and women involve sex and not gender, and rarely does gender operate outside the context of sex. And if we view the population of heart recipients, for example, the majority of the heart recipients are men. And now we know that chronic pain is a huge problem after transplantation, and it mainly concerns the female recipients. And then we need to ask ourselves, how does the fact that the men are in majority affect the encounter with the female heart recipients? For example, with extensive pain problems. Is there a risk of underestimating this problem? And we also need to think about how do men and women communicate their symptoms, because we know that symptoms is often a matter of communication and meaning making. And it is possible that from both a sex and gender perspective, we communicate and create meaning differently regarding our symptoms. As Anna mentioned, both females and males have profound hormonal changes. Is it possible, for example, that the pronounced problems with pain among the female recipients are due to the hormonal changes, for example, during menopause, where you can have severe joint pain or widespread ache in your body simply due to the fact that there are profound hormonal changes. And perhaps we need to consider that in a more systematic way. We also know that these hormonal changes have not only physiological effects, but also produces a lot of changes regarding immune system, for example. And one of my key messages today is that we maybe should consider these effects, both when we plan research and also when we deal with different follow-up in the clinic. So in conclusion, we know today fairly well that female heart or lung recipients experience higher pain intensity as well as worse sensory and affective burden than male patients. They have a higher odds of experiencing pain, and also there is a link between psychological general well-being and the experience of pain problems. And we can tentatively conclude that the higher psychological well-being, the lower odds of experiencing pain when adjusted for sex. So my take-home message to you today and the implications is that I think we need to acknowledge that female organ recipients might suffer from a higher symptom distress than the male recipients. And specifically regarding chronic pain, it is a prominent problem. And I think we should assess and deal with the differences in symptom burden based on sex in a more systematic way. And also we need to understand that every setback and complication also affects self-efficacy negatively. And self-efficacy is a driver in self-management, which is a goal for all of us, that the patients reach a good self-management. It also is linked to the aspects of person-centered care, because the most important aspect of person-centered care is being taken seriously. And if we are supposed to take the patient seriously, we have to understand how they communicate and experience their symptoms. So, sex and gender analysis enriches transplant medicine by analyzing how sex and gender influence all the phases of transplantation. And this approach prioritizes analysis to guide efforts to achieve a gender equality during the post-transplant follow-up, and also to enhance the lives of both women and men after solid organ transplantation. And I think we can save this one for discussion. Are we ready for a gender-specific follow-up? Thank you for your attention.
Thank you so much, Anna, for a really informative and insightful presentation. I have about 25 comments and questions, but in the interest of time, I will keep them for later. So we also ensure that we have room for a Q&A session, because I already see a few questions coming in. So it's now my pleasure to introduce Fernanda Ortiz, our next speaker. Fernanda is the head of the outpatient clinic at the Department of Nephrology of the Helsinki University Hospital. Her research work focuses on complications after kidney transplantation with a PhD on chronic allograft nephropathy. She's been a principal investigator in several multi-center trials, and her clinical work is mainly as a senior physician as she oversees the Living Donor Program in Helsinki. She's been involved in educational activities for nurses, nephrology fellows, and works very close with kidney patient associations. In the last year, she also became the project manager for the e-health program in nephrology. She will talk about the rationale for gender-specific follow-up. Thank you, Fernanda.
Great. Okay, so thank you very much. And well, this is my disclosures, and then this is how you can contact me after this talk in case you want to. And a quick guide for this talk, very briefly, in the interest of time, a couple of words about cancer, infections, cardiovascular disease, some pharmacological differences, and a couple of words of appearance and health literacy, and then we'll wrap up. So we know that in cancer, there are a different rate of toxicity to chemotherapy. There are different response rates, better response rates in women, and better survival after cancer treatment. And maybe that this increased toxicity in females could be directed to the fact that many of these drugs are actually adapted the doses to the estimated GFR, because many of them are metabolized and eliminated by the kidneys. And we know that when we use estimated GFR with any formula you want to use, we know that it's less accurate in females because the muscle mass is lower in females. And estimated GFR also is very different in small size or big size people in amputees. So this could be very important in cancer patients who may be cachectic. So that could explain an increased toxicity of these regimens. Among all the cancers, I would like to say a couple of words about the most relevant cancers, is like lung cancer and colorectal cancer, because there are some very interesting differences. With respect to lung cancer, of course, we know that male usually smoke more than females, but it seems to be that females are more are more affected by the carcinogenics that are included in tobacco. And this could be because there are genetic differences, as has been shown that lung cancer tissue showed more TP53 gene expression, and women had less, more inefficient DNA repair efficacy. So although they have less tobacco exposure, women are more suffer more serious effects of smoking. With respect to colorectal cancer, the prevalence and the male-to-female ratio varies across life. So in the younger population is mostly the same, but as time goes by, male patients are more likely to develop colorectal cancer. However, if we think about colon cancer altogether, we can see that proximal cancer is more frequent in females, and colorectal cancer, distal cancer, is more frequent in males. And this can be explained by genetics and epigenetics. So when you think about follow-up of our transplant patients, the symptomatology would be completely different in both sexes. So if you have a woman with anemia, maybe thinking about proximal colon cancer will not be before the first thing that comes to your mind. I hope that now you guys think about it in a different way. What about infections? Well, the most common urinary tract infection affects a kidney transplant population, but it's just the length of the urethra that we were talking about all the time to our patients. If we think about pediatric population in children below age 2, are almost the prevalence the same between boys and girls. And if you think about the geriatric population, maybe age over 65, the UTI is almost the same in males and females. And we know that estrogens in particular have a very strong influence in this prevalence. And if we have these female patients with repetitive UTI, we know that local estrogens are beneficial to prevent this complication. When it comes to influenza, unfortunately, we do not have data from humans, but there are some very interesting experiments from mice. For example, female mice have more morbidity and mortality after influenza. And if these female mice, the ovaries are removed, these differences are not seen anymore. But on the opposite, given exogenous estrogen after this could reverse, and actually they could have benefit. So here the point is that maybe when we talk about sexual hormones, it's not the same to think about endogenous estrogens or exogenous estrogens. And in particular, when you give estrogens to a patient, it's different if you give it orally or you give it parenterally. And so the protective or deleterious effect should be maybe different, but we don't know nothing about this in the human population. And we know, as Anna mentioned before, that it's just more than X and Y's, and the X chromosome express a lot of more genes, and that many of them are related to the immune response, as in the X chromosome is expressed the toll-like receptor 7 and the interleukin 1 associated kinase. So it's much more than just sexual hormones. In my particular experience, we have a work in type 1 diabetes under renal replacement treatment, and it was a nationwide study. We collected over 2,300 patients, and we came to the truth that the standard mortality ratio in females is ridiculously high compared to males, and this is particularly the case for women on dialysis. But even though these risks are reduced after they receive a kidney transplant, if they return to dialysis, if the kidney transplant fails, this risk is very high compared to the background population. And keeping the kidney transplant alive reduces the risk, but anyway, is double the risk of males. So for the purpose of this talk, I came back to that database and I calculated, as we take a look at the cost of death in all this, in the whole population, I compared, of course, the most common cause of death in the kidney transplant population is the cardiovascular disease. And there were no differences in these both groups. But the second most common cause of death was infection. And I came to this value that females with type 1 diabetes are more likely to die after an infection complication than males. And this difference was significant. Let's move to coronary artery disease because it's the most important complication in our population. And I took as an example this very new publication in a very prestigious journal, and it's the secondary analysis of the ischemia trial. So in this trial, they included patients that have moderate or severe ischemia on a stress test, and they were afterwards blindly selected to undergo a cardiac CT scan. From the participants, over 8,500 participants, only 26% were women. So women were underrepresented in this study, as in many other studies. And then the core laboratory actually selected who should undergo the coronary CT scan. And women were less likely to undergo this study. In the results, the researchers found out that women have more frequently hypertension, although they have the same amount of drugs than men, but they have higher blood pressure, they have higher cholesterol, less use of statins, less use of antiplatelet or anticoagulants, and women were more likely to have a non-obstructive cardiovascular disease. So in conclusion, they found out that women have more frequent angina, less extensive coronary artery disease, and less severe ischemia. The point is that what is the method that they use? So if you find out what are the cardiovascular, the coronary artery disease phenotypes, what they were studying was just the most common male phenotype, that is the obstruction in the epicardial coronary arteries. But in women, we know that there's another phenotype that is much more common, and is the non-obstructive and microvascular ischemic disease. So why this is important? Because the consequences are exactly the same. So they are both affecting morbidity and mortality, both in males and females. So if we want actually to study more cardiovascular disease, maybe we should perform PET or cardiac MRI, particularly in the female population. This very interesting study is showing that in women with anxiety and no previous history of cardiovascular disease, they have more frequently actually cardiovascular disease than women without anxiety. So maybe this anxiety is mostly related to this coronary complication than to a psychological stress. And this study is actually very alarming. This was made in the US. And they take a look of all the patients that were treated in the emergency room due to a coronary acute syndrome. And at the moment of discharge, they realized that women were less likely to be released with aspirin. They had less likely beta blockers prescribed or an ACE inhibitor, and they have received less consulting about smoking cessation, and they had less likely indicated statins. And there was another very interesting, very similar results come from China on a study on primary health care in over 45,000 patients with known cardiovascular disease, and they found exactly the same. Women were less treated. When it comes to pharmacological differences, it seems like the response to statins is different, that males are more likely to reduce the LDL levels than women. But in women, they can experience a regression in the coronary atheroma with statins, but they need to get a lower LDL target. There are many sex-related disparities in pharmacokinetics, and some of them could be clinically relevant and some of them are not. But anyway, it will be very interesting to keep them in mind. When it comes to cardiovascular disease, beta blockers are one of the most indicated and prescribed drugs. And we know that the benefit is similar in males and females, but there is a greater drug exposure and more adverse events in females. Calcium channel blockers also are in elderly women more likely to be clearance easier. And with respect to ACE inhibitors, women are more likely to develop adverse effects like dry cough. Diuretics can provoke hyponatremia and hypokalemia more frequently in women than in men. We have an ongoing study on e-health literacy, and this is a non-publicated data, an interim analysis. And from our population, we know that female have higher e-health literacy. They know where to find helpful health resources on the internet. They know how to find it and how to use it, and how to use it for the benefit of getting better health information. And we know from previous studies that women are more adherent to the medical treatment. So maybe we can use this as a very good tool to enhance the women's health. So to wrap up, we know that many non-sex related cancers could have a different clinical presentation. They have different prognosis and different response to chemotherapy. And that death secondary to infection is much more common on type 1 diabetics females under renal replacement treatment. Women are more likely to have angina, but less likely to undergo a revascularization procedure, and they have more frequently non-obstructive and microvascular ischemic disease that has been diagnosed. And there are some metabolic changes in the pharmacokinetics that should be taken into account. The quality of care in women with coronary artery disease needs to be improved, and maybe digital health solutions could be a good tool to improve self-care. And that's all from my part, and thank you very much for being there.
Thanks a lot, Fernanda. Huge amount of issues on the table, even too much probably because we are short on time, but lucky enough we can extend 10 minutes for a little bit of discussion. And I would like, Valentina, if you agree to open to question and answer, we have some.
Absolutely.
If I can start with the very first question, and then you follow, Valentina. A question for Anna Breithaupt. There's, I mean, underline that the one that's been presented is a very elegant work, so congratulations. So, but the question, do you think that alloimmunization to the pregnancy plays a role in any of these differences? And in particular, did these animals have pregnancies previous to the studies or not? So the variable of pregnancy as a determinant of changes in behavior in your setting, in experimental setting.
Thank you. The idea of pregnancy, we did not analyze at all at our study. Our animals are young adult rats. They have already started to cycle, and the cycle of rats is a little bit different from the human cycle. It's shorter, a lot shorter. And we normally focus on animals with high estradiol content for the induction of brain death. We separate the rats by cycle in order to have higher levels of estradiol. The idea of pregnancy brings me the knowledge that they have a lot more hormonal circulating. They have more progesterone, more estradiol circulating. That changes a lot. The responses of pregnant women is different and normally influences the future. If you have a woman that does not have child at all, the answers after pregnancy changes. There are some literature about it that pregnancy alters the physiological response in the future, can alter some aspects, but the genetic thing is not changed. So the hormonal milieu influences a lot, and that is our main focus. What is the content of hormones in these donors? But we focus only on brain dead donors. Maybe living donors or DCD donors has not the same picture because they have the hormonal normal.
Valentina, I need to make a comment on that. Sorry if I may, just to clarify, because we need to try to simplify in a way to take home something. So we are supposed clearly now on, even in a transplantation setting, we know in the whole other issue of medicine that we need to stratify our behavior according to gender. But the question is to everybody, to Anna and to the Annas and Fernanda, should we substratify the female group in premenopausal and postmenopausal? Because clearly there is genetic differences, but as you said, you know, the hormonal impact is so relevant. So we at least have 3 groups for clinical and experimental behavior. Is that correct? I would like to hear from all the Annas and Fernanda.
I believe, yes, it's very important to consider, because when we think about menopause, we think about aging too. And we cannot dissociate the aging process for the female too. It influences the hormonal and the aging, because the menopause women are older.
Anna Forsberg?
Yes, I think that would be a useful approach, and specifically regarding the pain problems, because my hypothesis is that some of them actually are very closely linked to the menopausal period, like a joint pain, for example. It's very common also for non-transplanted women. So I think that would be a good thing to start with.
Fernanda?
I think that's very tricky, mainly because in the postmenopausic population, the problem is that some of them are receiving exogenous estrogens or progestins, and they are very different. And it's a different way if they are taken them orally or parenterally. So there are some studies showing that the cardiovascular disease is different. Maybe the hormonal replacement could increase the risk of having a cardiovascular attack, and others shows the opposite. And the point is that it's very difficult to see, you know, the estrogens go the first metabolism to the liver, so they could be maybe more hyperaggregation and then provoking more usually thrombi and provoking a cardiac attack. And it's different if someone is receiving this in a gel. So I think that just dividing by age maybe it's just an approximation, but it's not the whole truth. We have to be very careful with that.
Valentina, to you. Thanks, Fernanda.
Okay, so we have another question in the Q&A box and several comments in the chat. So I'll alternate with the chat now. Vincent says that in the LTR registry, we found by comparing the graft survival of the first sex matching donor recipient groups that the graft survival in the FM group, female donor to male recipient, was significantly lower than the other groups, while the survival of the female to female group was similar to the other 2 groups. And he suggests that this issue should be elucidated for better use of grafts. Anna had replied to that comment. I don't know if anyone wants to add anything to that point.
I'm supposed to do it since I'm a liver transplant surgeon. I mean, thank you, Vincent. The point is absolutely well taken. There is, I would say, relevant amount of evidences out there supporting this point. And but now the real crucial issue is that the pressure in order to allocate organs is so high that many times we do not have the chance to choose also according to gender. So it's something that every clinician has to take in mind clearly, but in many instances we are forced from, you know, the need of transplantation of the recipients, and that's an absolutely nice point. And I would like to see the pathophysiologic link behind that. This has not been elucidated so far, so there is huge amount of room for investigation. Valentina, next.
We have another question for Anna Breithaupt. What type of differences do you believe that need to be investigated in the management of male and female donors? From Luis Felipe Moreira.
I believe the most important part when we talk about female, it's the inflammatory milieu, the inflammation response after brain death or after transplantation, after ischemia. And we have to consider if the recipient is a female, she has hormones, she has estradiol, she has progesterone. The organ is coming into a body with hormones, and these hormones are going to interact with the organ. The inflammatory interaction, estradiol and progesterone, they have clearly anti-inflammatory aspects involved. They influence a lot the immunologic response, and that should be considered, not only in the donor, but in the recipient. There is a large room for research. We should consider that for female, the inflammation, and maybe for male, the coagulation process that we observed in brain dead donors. Maybe the clot formation for the organs, maybe flush the organs, consider using anticoagulants in the donors. I don't know, it's just an idea for clinical questions.
Thanks a lot, Anna. Just my curiosity, in the meantime, Valentina looks to further suggestions. So do you have a gender-specific follow-up, I would say scheduled, or for dedicated to gender already in clinical practice, in your day-by-day clinical activity?
We don't have it not at my center in the south of Sweden, and I'm familiar with any center actually in Sweden having a gender-specific follow-up. Although I think it's high time. I think we need to consider this as an option. Typically, if we are going to pursue with person-centered care in a more efficient way, because then we have to see the person behind the problems, and it could be a sex issue or a gender issue, or just the way you are and the context that you live in and the responsibilities you have in your family, and this together forms a symptom burden or an experience of a symptom burden that we need to pay individual attention to. So I meet the patients. Their key complaint is that when they meet their physician, the physician always focuses too much on the organ, too much on the graft. They mention their problems, their symptoms, their distress, and the most common answer is, but the heart is good, or the kidney is working fine, or the liver is nice, so don't worry. And I think that's a huge problem. We need to change the approach to focus more on the whole person.
Agree, absolutely. Fernanda, you want to comment on
that? Just the same. We don't have any specific follow-up so far. And I think what Anna mentioned is just is heartbreaking. But many are focused just on lab tests. Oh, your creatinine is great. Just go home. Everything's going right. And we don't have a holistic approach of everything, because it's now that, okay, the organ is working, but your quality of life is very poor. So if you are complaining because side effects of the drugs and so on, so your life is not getting any better, we just focus both for females and males in the same way. When we think about sex differences, I think that many of our colleagues think about, well, what about breast cancer or a gynecological follow-up? Or I think that we have to go far away from that. We have men with osteoporosis, and we are not detecting that. And there are many issues that go far beyond hormones. We are not developing that. We are trying not that we are just making new portals and websites and e-health technology developing. We're trying to figure out to who are we developing that, just to be more targeting that, and to empower the people if the doctor don't have the time, because the problem here is that we don't have enough time. Never we have enough time. So is there any way that we can help from other things? Working more with patients associations, for example, having the help. And I think that maybe some champions, like patients that are given and giving more help, and maybe just exchanging experiences will be very creative. But we are very far from where we would like to be.
Valentina.
Yeah, I'm afraid we need to start wrapping up. But if I may, just a really small comment from a non-medical, a non-healthcare point of view. It seems that paying attention to sex and gender is definitely not only an ethical or social justice related matter, but it makes the difference in terms of adequate research, adequate knowledge, and adequate care as a consequence, as you were expressing, Fernanda, and I think that's really important, and a lot of education probably needs to happen in this respect, and research, of course. But maybe, Umberto, we can start wrapping up.
Sure.
There are still a lot of comments and questions, and this is just a sign that we need to continue doing what we've been doing tonight.
Absolutely. I need to launch the poll. There is a poll about the appreciation of this webinar. In the meantime, that the people is assessing their opinion, I would like to say that I am absolutely happy about this webinar, because this webinar is exactly an example of personalized medicine kind of area. Everybody is talking about personalized medicine, but in reality, in a few situations, really, we take care of the person and not only about, his or her biological needs or clinical needs. So I think that looking to the person, gender, sex, particular characteristic is the way to go in the direction of personalized medicine. I don't want to be too, radical, saying that the guidelines era is in the phase of conclusion. Now we are going to think to a medicine which is very much dedicated to the person and to the human being, each person, each patient personally. And saying that, I think that artificial intelligence is the way to go, because the amount of variables that you talk about cannot be managed, to me at least, in a normal clinical setting. We need to have computational medicine in that, but it's just my impression. Extremely useful, 77%, and useful, 23% of the participants. So thanks very much to the speakers for the outstanding presentation. Very happy of hearing you, having these pieces of information about the topics, and thanks for everybody that has a chance to attend. I don't know if I have 1 minute, Valentina, to say about the conference that will be again held in Milan, and we are going again to advertise about a few webinars that will precede the conference. This will be ex vivo lung perfusion, state of the art and perspective, May 11, again 6 p.m. Central European time. And please go to the platform. The other one that I am particularly, I like particularly, is the onset of the liver transplant oncology era. You heard by Fernanda how the oncology is now massively entering into the picture of transplantation. That will be May 19, 5:30 Central European time. Again, please go to isotcongress.org in order to look at the program. Is a huge amount of topics. We have done that with a huge amount of enthusiasm. I hope that you will like it. And that's it. The word to Valentina for the final conclusion. Thanks a lot for being here today.
Thanks, Umberto. We'll close real quick. I'll just remind everyone to visit the ISOT website and complete the survey on equality, diversity, and inclusion. I invite you all to register for the ISOT Congress, but Umberto has already warmly done so. And last but not least, you'll be able to watch this webinar and the other webinars on demand on our channels soon. Thanks again for being here. Thanks again to all the panelists and to a very lively audience. It's been a pleasure. Thank you. And goodbye.
Good evening, everybody.
Bye.
Bye.